next talk, that is role of tranexamic acid in resuscitation when in polytrauma, when and for whom. I would like to invite Dr. Pragyan, HOD Critical Care at Care Hospital, Bhubaneswar, and he's a East Zone member for ICCM and for Society of Neurocritical Care. And it is fascinating to see his areas of interest. Sister empowerment, very good. So nurses empowerment, I
So
think.
after you
Thank you.
people have used antibiotics, I have nothing left. Only sister empowerment is the only thing left, I think. So very, very good afternoon, all of you. At the onset, I would like to thank team ICCM Hyderabad for inviting me over here. So before I go forward, I'd like to quote a very beautiful study done in Harvard in 2022. So they said that in any academic session, post 1 hour lunch, maximum people doze off. So let's see how many of you are dozing off. So please raise your hand if you're sleeping or if you want to REM sleep or something like that. Only sleeping. Oh, that okay, good. You got it. Then all of you are not sleeping. That very nice, very nice. Thank you. Thank you. So be with me for 15 minutes. We'll quickly cover down tranexamic acid, when and for whom. I think one speaker of my stature cannot answer only 2 questions. I'll answer a few more. I'll walk you through when to be given, where to be given, whom to be given, how to be given, how much to be given. Please bear with me. So as we know, each year worldwide, about 3 million people die as a result of trauma, many after reaching hospital. Among trauma patients who do survive to reach hospital, bleeding is a common cause of death. They account for about 1/3 of in-hospital deaths. And most of the preventable trauma deaths are due to bleeding, which can be exacerbated by trauma-induced coagulopathy, involving plasmin-mediated fibrinolysis resulting from tissue injury and hemorrhagic shock. Tranexamic acid is an antifibrinotic agent used to prevent traumatic exsanguination. So we have these two beautiful systems, as you can see, a coagulation cascade and a fibrinolytic cascade. So with intrinsic and extrinsic pathway going down, as we all know, the cascade, it ends down in fibrin. And in a fibrinolytic pathway, you can see tissue plasminogen activator at the end converts plasminogen to plasmin and helps to convert fibrin to fibrin degradation product. And so to make the fibrin appropriately adhere, plasmin system needs to work, like a fibrinolytic system needs to work. To make coagulation work better, coagulation cascade needs to do good. So if you can say, tissue plasminogen activator converts plasminogen to plasmin, and that in turn converts fibrin to fibrin degradation product. And these two things indirectly helps to keep the clot firm. So if you can see in this picture, the tissue plasminogen activator activates plasminogen. Plasminogen gets attached to the fibrin through this lysine binding site and indirectly converts into fibrin degradation product. But in a trauma, in a coagulopathy situation, this system goes disarray and FDP forms rampantly. So fibrins are broken down. It's a pathogenesis of a lot of bleeding. So what does tranexamic acid does? It attaches to lysine binding site and prevents binding of plasmin to fibrin and hence prevents formation of fibrin degradation product. This is how it acts. So let's answer question number 1. Tranexamic acid, when it is to be given. So we have this trial called CRASH 2 trial, a randomized control trial and economic evaluation of the effects of tranexamic acid on death, vascular occlusive events, transfusion requirements in bleeding trauma. We'll be answering mostly about death. As we understand that tranexamic acid is very notorious and has been perpetuated to cause some sort of vascular occlusive event. So we have to take care of that as well. So coming down, so they took around 20,000 patients or so. Half of them were given tranexamic acid and roughly 10,000 were given placebo. So what they found out? They found out that in this forest curve, as you can see, anybody who was given a tranexamic acid more than 3 hours after injury had cost, it was not of much benefit. But those subset of patient where it was given within 1 hour or between 1 to 3 hours, they have some sort of benefit. Tranexamic acid is better in those patients. So this forest curve proves that if you are giving tranexamic acid little bit earlier than 3 hours, you are getting the benefit, some sort of mortality benefit. Plausible explanation could be TP is acting as a potent agent of fibrinolysis and is activated following tissue injury, and its level reaches a peak concentration about 30 minutes. The plasminogen plasmin levels also peak at 1 hour post trauma. Therefore, tranexamic acid acting to block plasminogen from binding to fibrin is most beneficial when administered within 1 hour time period, with below 3 hour post-traumatic injury. Administering over a 3 hour post injury has been shown to be of some little bit bad for the patient. This is another graph which has shown that tissue plasminogen activity level increases significantly just after trauma and started dropping down after 3 hours. Coming down to another aspect of trauma, whether this 3 hour period that was proven in crash trial, whether it is acting on all scale of GCS, all types of injury, all types of blood pressure. So to find the answer, they did a subgroup analysis of the same study. Same group of authors did that. They tried to find out whether this same concept of within 3 hours is acting on GCS across will be less than 8 to more than 13, or blood pressure less than 80 to more than 120. So answer is very clear. So when given within 3 hours of injury, tranexamic acid reduces death due to bleeding regardless of type of injury, regardless of GCS score on admission, regardless of blood pressure. So that's pretty interesting. So 3 hours is a very good pretty period. So answer to question number 1 is that preferably within 3 hours of trauma, tranexamic acid should be given. That is clearly proven by crash trial. Question number 2, where we need to give it. As you people must have understood by this time that 3 hours is pretty narrow margin. It is very difficult for the patient to reach hospital within this period of 3 hours. So hospital scenario goes out of questions. So we need to administer tranexamic acid probably in pre-hospital scenario, probably in an ambulance or at a site of trauma. So that becomes very precarious. So whether we need some studies to find out whether we can administer tranexamic acid at the site of trauma or while traveling to the hospital in an ambulance, let's find out. So this is a very beautiful study which they try to find out the effect of pre-hospital tranexamic acid on outcome in polytrauma associated with severe brain injury. As you'll be traveling through my slides, brain injury is little bit different subset when you are discussing tranexamic acid, but we'll see what they have done. So they did a 7.5 year span, a period of 7.5 years. They did a prospective cohort study. They took consecutive trauma patients with associated severe traumatic brain injury, and they gave tranexamic acid to hemorrhagic shock and wherever systolic BP is less than 90. They found out that there is no difference in overall outcome between tranexamic acid and non-tranexamic acid group. So that's pretty interesting. So in a pre-hospital scenario, they could not find any mortality benefit over here. Let's find out some other study. This came 1 year back at NEGM patch study done in New Zealand, Australia and Germany. So they also did the same thing. They tried to find out whether ambulance giving of tranexamic acid is helping the patients or not. Roughly they took 1310 patients, 600 odd are given tranexamic, 600 are taken into placebo group. And as you can see, there is not much change in the forest plot. And across the Glasgow outcome scale also, there is not much difference between tranexamic acid and placebo. Like if you say death, similar in both the group, even good recovery, similar in both group, all the disabilities are similar in the both groups. So they concluded that in a major trauma, treatment with tranexamic acid did not result in a greater number of patients surviving with a favorable outcome at 6 months. But the interesting part is that tranexamic acid has been notoriously always accused as causing some sort of thromboembolic event. So this NEGM study, what they did, all inpatients were subjected to go for a Doppler to find out whether they have DVT, those who have received tranexamic acid. So they have interestingly found that they've screened all inpatients for DVT in the legs. They found little evidence that tranexamic acid is increasing the risk of such events. So they concluded that tranexamic acid, although you are given, although it is not causing mortality benefit, it is not causing any harm. There is no increase in DVT or any thromboembolic events if you are giving tranexamic acid to these trauma patients within 3 hours or so. This is a very beautiful review article which again addressed the feasibility of giving tranexamic acid in an ambulance scenario. So this is given by Raquel Stansfield. So use of tranexamic acid for the management of hemorrhage in trauma patient in pre-hospital environment. So they found out that tranexamic acid remains viable when stored between 20 to 50 degrees Celsius for less than 12 weeks. And it showed to continue to inhibit streptokinase induced fibrinolysis of platelet poor plasma by different studies like they did D-dimer, they did FDP. They found that it is still effective even if you store for 12 weeks. Of course, care needs to be taken while defrosting. So they have concluded that in a civilian pre-hospital setting, tranexamic acid was shown to cost between $40 to $64 per life year saved, making it highly cost effective and accessible option to ambulance service. So this study showed that there is some benefit, mortality benefit of tranexamic acid in a tune that roughly if you spend around 5,000 to 6,000 rupees, you can save one life year. That's quite remarkable. So answer to question number 2 is that studies have proven that it is feasible and can be given safely in a pre-hospital settings, especially in an ambulance, without any increased complications of thromboembolism. Now, whom to be given? Which patients are candidate? So for that, we have this beautiful CRASH2 trial, a randomized controlled trial of economic health, as I had already discussed. And this is the forest plot I've already shown you. So this part says that wherever there's a BP of less than 75 and tranexamic acid was given, systolic BP, there you have got some sort of benefit and tranexamic acid arm is little bit better. And another study, association of tranexamic acid administration with mortality and thromboembolic events in patients with traumatic injury, they have also shown that tranexamic admission was associated with 17% decrease in 1 month mortality compared to the control group. Even they have found that patients with multiple traumatic injury may benefit from tranexamic acid administration than patients with traumatic brain injury, in particularly when the leading pathological finding was hemorrhage along with clinical signs of shock. So in subset of patient where there's a hemorrhagic shock in a polytrauma, they fare better in tranexamic acid arm comparison to traumatic brain injury. So our next trial is CRASH3 trial. Seeing the positive results in CRASH2 trial, CRASH3 trial was taken, specially taking into subjects of traumatic brain injury. So they took 12,737 patients and half of them were given tranexamic acid within 3 hours of a traumatic brain injury. And they interestingly found very good things actually. So they found that whenever GCS is mild to but between 9 to 15, tranexamic acid group is faring better. Whenever GCS is too bad, less than 8, it is equivalent. While when people are reacting good, tranexamic acid arm is doing good. So, and if you go a time bound section also, when a mild to moderate GCS between 8 to 14, with time the mortality increases, but if you give early, you get some benefit. While if a very bad GCS less than 8, it doesn't make any change. So CRASH3, they have concluded that there's a substantial reduction in head injury related deaths with tranexamic acid in patients with mild and moderate head injury with no apparent reduction in those with severe head injury. So the message is very clear. So answer to question number 3, whom to be given? Patients with polytrauma with hemorrhagic shock benefits the most. Mild to moderate traumatic brain injury may also benefit. Question number 4, how to be given? So we have two routes, IM versus IV. As we are discussing, it should be given in a pre-hospital scenario. Then IM also become feasible because IV access may or may not be available. So a lot of studies have proven that both IV and IM routes can be considered in emergent situations. Studies have proven that efficacy of tranexamic acid in control of bleeding and mortality is not significantly affected by the route of administration. You can give IV, you can give IM, you can have the same benefit. But there is a mild increased risk of thromboembolic events when tranexamic acid is delivered through IV route compared to IM. Very minuscule, but that we need to think about. Then how much to be given? Coming to how much, the different studies have taken up different doses. So commonly we have taken a loading dose of 1 gram followed by a 1 gram infusion over 8 hours. Some studies have taken only 1 gram without any infusion. Some studies have taken a loading dose of 0.515 milligram per kg up to a maximum 1 gram. Some studies have taken 1 gram start followed by 0.15 milligram per kg infusion over 8 hours. So among the different studies that have taken up different dosage formality, we tend to follow the CRASH2 trial, which has given maximum mortality benefit to the patients. So this trial had used loading dose of 1 gram followed by a 1 gram infusion over 8 hours. I think this is the most appropriate dose that is practiced across world because CRASH2 has proven it. Even CRASH3 trial also tried to use the same thing. So answer to question number 4 is loading dose of 1 gram over 10 minutes, then infusion of 1 gram over 8 hours should be the right dose to be given, appropriately proven till date. Further studies can prove us wrong, so let us wait till that. So to summarize, tranexamic acid safely reduces the risk of death in bleeding trauma patients. It appears most effective when given early after the trauma, regardless of blood pressure, GCS or type of injury. It should be given only within approximately 3 hours. Treatment beyond 3 hours of injury is unlikely to be effective. It has maximum advantage in polytrauma with hemorrhagic shock. In traumatic brain injury, it is beneficial in mild to moderate severity. And yes, it is feasible and safe in pre-hospital settings like ambulance. I think I should be given a prize because I finished 30 seconds before. Thank you so much.
Thank you, Dr. Pragyan. So you'll have more questions because you finished earlier. So thank you for that insightful talk once again. So I would like to call all the speakers on the stage, Dr. Mithilesh, Dr. Srujan, Dr. Varalakshmi, and Dr. Pragyan. So quickly we'll take some questions because we are already running late. So if any questions, no questions. All of us are sleepy post lunch session. Yeah.
Good afternoon, sir. How about subsequent tranexamic acid doses, sir? You said 1 gram start dose and 1 gram after over 10 minutes, sir. Over 1 hour, sir. What about
One
second,
gram
third day?
start, then over 8 hours. That is the only study that has been done till now. After that, it hasn't shown any benefit actually. We are
Okay.
talking about trauma patients, this
So
subset of patients.
in total, only 2 grams, sir, in trauma patients.
To start with.
Yeah, okay. Thank you, sir.
Further studies can clarify better, but not yet proven.
No further questions. We'll conclude this session. Thank you.
Intriguing and thought-provoking topics in trauma. So I would like the chairpersons to give away mementos to our speakers. Dr. Varalakshmi.